let's talk about eyes. Today, we're going to talk about some refracting. Refracting is probably one of the things that is the most simple, but the most complicated at the same time. It takes both your thoughts, your attention, their previous glasses, what their history is, and all of that kind of adds up to what you do here, how you do it, and when you do it. So one of the biggest problems that people have is that they start with their glasses prescription in the 4-diopter. That is never what you're supposed to do.
You don't want to do that. You want to see how their glasses sit on their face. How do they, because that's their everyday life, is how they sit on their face, how they're looking through them. And so, yeah, always make sure you check their vision if their glasses are with them, with their glasses on.
Document the type of condition that the glasses are in.
I just did that today, actually. Yeah, because when I went to do the refraction, his vision was actually better with the same glasses prescription results as what he was wearing, but his one lens was very scratched, and some of the
so he ended up, the coating was coming off.
Yep.
So it's important to explain to the patient why we are doing the refraction. The refraction is a key diagnostic tool that the doctor uses to help determine the health of the patient's eye. It is a medically necessary for us and what we do. A lot of patients don't consider that. They come in, they're like, I'm seeing 20/20. But you can tell sometimes with refractions whether or not somebody's having swelling in the back of the eye. Are they taking more plus? Is somebody having cataracts? How they're responding to it. As soon as those room lights go down, some people are like, I saw better with the lights on, because they're having a little bit of a pinhole effect, with those lights on.
Sometimes even with people with macular degeneration, listen to what they say when they're looking at the letters through there. The letters jump. The letters will be jumpy.
Yeah.
That's a key note to make.
So you can do your Amsler grid in relation to having your refraction done. But one thing that I can put on just a tidbit, never check pupils prior to a refraction.
Right. Yep.
You do that, you're flooding the retina, and a lot of people, they make this being the next to the last thing that they do, and it shouldn't be. The pupil should be one of the last things you do once you know that you are done with your refraction. That's very key, especially with people who have macular degeneration or any other type of retina problem, cataracts. Sometimes those lights get trapped in there because we are light benders. Refraction actually means the bending of light. We gather information from the people, so technically you could say we're information gatherer light benders. And that's a very good way to present it to patients so that they understand we're trying to determine. There's a lot of different things that go into a refraction, from the cornea, the tear film, the retina, the lens of the eye, and all of that has to be in alignment for people to see 20/20. But there are times when people can see 20/20 and everything isn't perfect.
Their prescription might, and their prescription is wrong, actually. Overcorrected. Prime example, today I had a lady come in, the last 4 visits that she had been here, she had been a -4. She was spherical, she didn't even have astigmatism. Her auto in her case showed the same thing, showed her at a -425 in each eye. But you never start with your refraction. That's one of the most important things to remember. A lot of people are like, where do I start? What do I start with? That's one of the key things in a lot of interviews. You can ask technicians, what do you do when you refract? Where do you start? It shows your level of where you're at when it comes to refracting. I start with at least 75 cents worth. Each piece I call a quarter. And it's a good way to explain to the patient, how much of a change did you get? Well, this is what I got, but the doctor makes a determination as to what you need. But it's good to have a conversation with your patient saying, for every time I give you 25 cents worth, you're supposed to see one line better. If I start out at 75 cents less, I'll bet you every day I find at least 4 to 5 patients, at least,
that take way less the power that they're used to getting.
And like you always say, they have to earn it. You know, they have to earn it. And I always, when I bring this in front of them, you're not ever starting exactly where their glasses say they are, and you should never start with the top con because that will always over minus. So I always tell the patient, now this is going to be a little blurry, but we're going to work on making this better. So that's the wordage that I use, is that, you know, when I put that out, I don't want them to think that that's what it's going to be.
So I always try to start, and this is me, you'll get your own way, but I try to start with 20/20. If I put up 75 cents less or a plus 75 over their glasses, they should not be able to see 20/20. And you'd be surprised at how many people are TZVEC. And then you're like, let's change that because
Yeah.
you just read it.
Yeah,
They see it again.
yeah,
They're just reading a different set of letters, and it's like, okay.
yeah.
So you have to remember, if they're reading 20/20 and you started at 75 cents less, you have got to take a step back and think, okay, this person is either over minused or they're under plussed.
Right.
And it's the most difficult thing when people are farsighted. When people are farsighted, you give them more. You're giving them plus every eye exam for a refraction.
As much as they'll take.
If they are farsighted, you start out with plus 75. If they are nearsighted, you start out plus 75 on top of their nearsighted exam, which means algebraically, if they're a -4 and I give them a plus 75,
You're going to start out at 2 1/4, minus 2 1/4.
and you're just going to work from there. It does not hurt you to dial in and make them earn that power. If they can't see it, I can't see it, that's very blurred. That's good. Now we'll work closer to where your true prescription is.
And you want to get to the point where it is no difference. That's your final, that's what you want.
Especially when you're doing astigmatism. Now astigmatism with the Jackson Cross, if you are refracting and you are not using a Jackson Cross, you should not be refracting.
Exactly.
Period.
Yeah.
I don't care who you are. There is no way you can get an accurate prescription. Accurate, I'm saying. You can try to refract without it, and you probably get away with it, and the patient probably will not know any difference. It's extremely important to be using the Jackson Cross. If you're an experienced tech and you haven't been doing it for years because you're trying to rush through things and hey, it doesn't make that much of a difference, just think of it like this. If you go to the doctor and you get a prescription, it doesn't matter what it's for, and you go out and you spend $700 on a pair of glasses and they're not right, you as a technician are not doing what is just and right for that patient because you didn't do this. Now, if they come back and we've done everything right, then that's a different situation.
And then, when you put this down and go to your Jackson Cross, you're always going to check your axis first. You got to know where that best corrected vision is and where that axis is first. It doesn't matter what your power is, you're going to check that after you check the axis.
One of the things with the Jackson Cross that people don't understand is you're giving a patient a choice between one or two. I always tell them these are the blurry lenses. They're not supposed to be crystal clear until you move that away. You're giving them a choice between one or two, or are they about the same? That question is so important because at some point in time, you're going to take away the power of the patient telling you which is better and use your brain. Today, when I had somebody who was a -4 and I started out at a 325, basically what ended up on happening, she could read 20/20. I worked through my Jackson Cross. She kicked out all of her SIL, and I'll be darned if she couldn't read 20/20 with 325. That ended up on being her prescription, ironically, but the patient kept saying, oh, that's so much better if you tried to give them more minus.
Yep.
It's so much sharper and darker. We all know that extra minus makes it
Sharper.
darker,
Darker. Yep.
but it also makes it a little bit further away.
Yeah.
And sometimes they have a hard time understanding that with what's going on in their brain.
Right.
And so those are the people that you're going to make sure you say, hey, I've got a large change in your glasses here. The doctor makes a determination how much, but you can't be bouncing back and forth between your old glasses. The body likes habit,
Yep.
whether that habit is good for it or bad for it.
Right.
Likes the same thing over and over.
Another thing when I do the Jackson Cross, what I have the patient do is focus on the second letter or the third letter in the middle. You know that if your axis and the power of your cylinder is not right, if that middle part is blurry to them. You can fine tune that, especially in your higher amount of cylinder patients. You can be off 5 degrees and they'll notice that. Not as much more when the quarter half diopter, not as much. But the higher amount of cylinder, your axis has to be straight on, right on, or they're gonna notice that. So that's why I always have them focus on one of those middle letters when I'm focusing on the axis and the power of the cylinder.
Key rule, and this is a big one. If it doesn't improve their vision by 1 to 2 lines, don't mess with the axis and the sill. You change your axis and your sill, people are gonna notice.
Yep.
And it's very important for you to take notice, where is the patient at if I make this change? Even if they pick it, you can annotate that. You have to communicate with your doctors in the comments. It's very important for you to say, I got this with 20/20, but you don't want to give that change if it does not improve their vision. And if they're already at 20/25 and you're improving them by a little bit, but you're changing their axis and you're changing their astigmatism, don't change that. Let the doctor know, patient liked this, this, and this, and saw this. Your communication to the doctor does not have to be face-to-face,
Nope.
even though I prefer that.
Yep.
But it
Not always
does,
possible.
it does have to be there. The doctor can't make the true decisions unless they have all the information.
Right.
So at some point in time, you've got to take away the power just because the patient liked the -4. She wanted her -4. But I made her sit here for about 1 minute to 2 minutes as I'm entering my information in, looking at the 325, showing her several different 20/20 lines.
Yep.
Then I packed this up, said, get your glasses
I've done
ready,
that too. Yeah.
and pop those on. Whoa, there's a big difference.
Yeah, right.
Sometimes just going click, click, click in here, you're allowing for accommodation, and that's not what you want. You can accommodate for years and years after what they say that there's accommodation. They're going to tell you, oh, you're going to start to lose it here, but
Yeah.
I know people that are in their 60s and are still accommodating, especially if they're nearsighted.
Right. Exactly.
Farsighted people lose that ability a little bit more so.
Yeah.
You have a short eye, you're bending the light closer to us.
And another thing I always like to do too is at the end of my refraction is open both eyes. Let them look at that final result with both eyes open.
Converge it in a little bit when
Yep.
you're looking for both, or else
Yep.
they're gonna say double vision or I'm not seeing well.
And then when you do you want to go into your ads. Your ads, make sure you bring these little guys in.
That's the muscle convergence.
And 16 inches, and I like to document 16 inches.
If a patient states that he works on the computer 90% of the time, gathering that information from the patient is key. You work all day long on your computer, 15, 16 hours a day. They're a workhorse. You can see that they're OCD. Don't mess with the sill unless it makes a difference in the glasses.
Yep.
And make sure you document. Patient works on the computer all day long. Interested in computer glasses, ask them if they have the blue blockers. Those help with some dry eyes. Dry eyes can make a difference in the clarity of people's vision. Many a times, our doctors are sending them away for a couple of weeks to use drops.
Yep.
And so that's why that documentation and the re-refraction is more important.
One other quick tidbit: if you do adjust this cylinder and you're taking that away, you're going to add, for every half a diopter you take away here, you're going to add a quarter diopter here.
So every 50 cents you give here, you're going to take away a quarter here.
Take away meaning more plus.
Yes,
Yeah.
always plus. It's the most important thing to remember.
Yeah.
The refraction is key to a lot of the people who come in here. That may be their chief complaint. It's not key to people who have pretty good vision in the distance and wear over-the-counter readers. Why do I need to check that? My vision is fine.
And I tell you what, you do a good refraction on a patient, the best compliment you can get from them is, I've never had that thorough of a refraction.
Another thing is, if you're newer at doing this, the patient doesn't know when you're here and you're clicking that you're moving slow. okay? There needs to be a consistency when you're doing it. You don't want to flip and wait, because then you're going to have some certain types of accommodation that you don't want.
Yeah.
It's important to be consistent with your flips.
Don't make them feel
Don't
rushed.
make them feel rushed.
But yes, exactly.
But it's like important for them to understand I'm going to go a specific speed so that there is not too much of a change inside the eye.
Right.
So your communication with your patient, you also have to know your patient as well. Use those powers of observation that we talked in number 1, or our pilot, I should say.
Yeah.
And take note. Does the patient have a big long list of things?
Yeah.
And make sure that if they do, that those get into the chart.
And one other thing we have to really make sure we focus on is, does it make sense? Does it make sense? Take that extra time to compare it to what they're wearing. What you enter is the last time that you're going to see that before they see the doctor. You better make sure it's right. Don't go through that fast. Does it make sense with what they're wearing? Did you flip a sign? Did you did you forget the decimal point? Did you just make sure it all makes sense when you're comparing the top con to their wearing to the manifest? Make sure it makes sense.
It's natural for cataracts, as cataracts are developing, to take more minus. You definitely want to feel that out when you're refracting them. If their vision has dropped and you suddenly are giving them a diopter and a half more, even though it's not on the plus side, please document that.
Right.
But you still want the least amount of plus, or minus.
Yeah.
Least amount of minus, that you can give them to give the best vision that you can.
Yeah.
So the most plus that you can give them to get the best vision. So they may take all the way up to a diopter, 2 diopters more, and they're seeing a lot better, but that's also going to affect their near vision.
Yeah.
So when you give them a lot more minus, you're taking away from their near. So some people end up on not going for cataract surgery for 6 months, 7 months. If that happens, they're going to need a good prescription.
And are they going to be able to tolerate all that you give them?
Yep. Always show them both eyes briefly in the distance and up close to make sure that they can tolerate that change.
Exactly. One other thing I wanted to add, we have a lens that we use that's a multifocal lens, more than one actually. Those aren't going to take your typical plus 250 at their post-op refraction. So you're checking their vision without glasses because they're post-op distance and near, documenting where they see that at. When you do their refraction, don't give them any at first on those multifocals. Okay, so sometimes they'll be able to read 20/20. Most of the time we hope they can. Once in a while, I had one from a few years ago that actually did need a +1 over top of her Restore IOL to see near. And then you just document that. But I had seen previously entries where it was given a 250, and that's definitely not right.
Yeah.
So you just have to make sure you're looking over the ocular
Does it
history.
make sense?
Ocular history, what kind of IOLs do they have in?
Yes. When we are doing a refraction on somebody, doctors all the time have the ability to do cataract surgery or do a corneal procedure. They get to make patients' vision better. This is the one thing that you get to do that can actually help somebody. And you can actually make their vision better. So when they come back, they're like, I want you.
Yeah, exactly.
And that's okay.
Yeah,
If
you
they want that,
yeah.
that's what you want, is somebody to come in. Now, it doesn't always happen where you have that ability.
The
but
more you do it, the better
more
you're
you
going to
do
get
it,
at
the
it.
more they're going to ask for you. And then that is one of the biggest compliments you can have when a patient comes in and says, I only want that person right over there.
It's important to get into your routine when you do it. I mean, if you do it, the same sequence every time, it's gonna be very, very comfortable to you, and you're gonna be able to recognize certain things that happen in that refraction as it goes on.
Now, there are times where we can't get anything on the auto. We don't know. They're coming in for refraction and we don't have glasses for them. They've had surgery. There are little tricks of the trade. Go to your more experienced techs. You can always ask somebody. There are little tricks where you can use corneal measurements to help you refract. But it depends on the type of implant you have. Learn your implant. Do a little bit of homework and study up on what it takes to get somebody where they're seeing 20/20 without.
Yep.
Sometimes that auto is not my favorite tool. Sometimes your favorite tool is just sitting down, looking at the paperwork, looking at what they were wearing, looking at the type of implant they picked, making yourself familiar with your electronic health record system so that you can look at it and say, hey, I know what this is, and this is. And sometimes it's like a little mystery puzzle. And you know, it's like, welcome to Mystery Theater. We're already in the dark all day long anyway. So you're already picking information from the patients. So the game of clue is there, but there are clues within clues.
Exactly. Another thing I wanted to touch on is sometimes the patient will say to this front office, I don't want a refraction today. And you know, that'll get noted on there. You take them back. Don't leave it at just that. You can talk to the patient, and I don't go right into it when I sit down with them. I see that note. I already know what kind of mind frame they're in. However, after you check their vision, you can go into that conversation of, it doesn't look like your vision is as clear as it was at your last visit. I see that we haven't changed your glasses in 2 or 3 years. I think it would be best if we would check that for the doctor today to determine if that's the cause of your decrease in your vision. Now, insurance might not cover that for you. However, it is necessary, medically necessary, to determine what's going on with your eyes. So you can get around that.
Especially our diabetic patients.
Yeah, oh yeah.
Diabetic
Absolutely.
patients, if you see a big change in their glasses or their vision versus, you have to have that glasses checked to see.
You gotta start there, because if it's not that,
then it's
what
going to be
is it?
something else.
Yeah,
And
yeah.
you want it to be this. You don't
right.
want it to be
especially if they
a
piss
syndrome,
well.
a dystrophy, or a
Yeah.
disease.
Yeah.
You know,
You
I
wanna
always
start
tell
simple.
people an aging change in the eye is actually a good thing, because most of the time we can take care of that somehow.
Yeah.
And it's either going to be with surgery, glasses, there's going to be a change somehow, or else they're just going to be walking around and not seeing. And so
Yep.
a lot of times that communication and that connection with the patient will help you figure that out.
Absolutely.
And so it really starts with the communication that you have with your patient, doing what's right in the refraction and not just flipping this. You know, it's so important to know that you have to do the Jackson cross. You have to take that time to look at everything and say, does this make sense? And if it doesn't make sense, there's no question that's a wrong question, even if it's asked twice.
Yep.
You always want to look at the whole picture.
Yeah, and ask for help. You know, that's why we're all here for each other, the ones who have been doing it longer. We want to help you get better at this, and don't be afraid to ask, because, you know, there's always someone that will be able to help you.
If you find you don't jive with a patient, switch out text.
Yep.
It's not that hard. There have been times I've gone to Barb and say, okay, Barb, you and I need to.
Yep.
And it works
It
out
works.
beautiful. And that's okay, because our job is to make sure that this patient
It's
gets the
happy.
best vision and that we are giving the doctor
The
the
best
most
information
that is the most accurate.
and makes
and-
their job easier.
So sometimes, hey, if they don't, not everybody likes me, not everybody likes Barb, but together,
We do our best.
we do pretty good.
Yeah. Okay, so we're gonna end with our
Do's and
our
don'ts?
never ever, always. I have the never ever start with your refraction. You don't want to start your exam with refraction. You want to
What they're wearing, you don't.
what they're, you know,
Yep.
yeah, you have to when you're doing the refraction, always start with what they're wearing.
Mine is always, every refraction, push plus. Push plus, push plus, push plus. They are nearsighted, you're gonna push that plus
Get that
every
most
time.
importantly.
And so keep in mind,
Yep.
it's all a math problem about bending light.
Yep.
And
And
so,
we're going to end with a tidbit from Dr. Ansari. He wanted us to throw this in here. He had a very sincere question yesterday. He asked me, how many ophthalmologists does it take to screw in a light bulb? And we told him
the answer is one
one.
or two, or maybe about the same. Next on the view, we're going to talk about ptosis visual fields, the right and the wrong way to do it.
And our guest speaker is going to be our very own Dr. Piotrowski.
Have a good day.